So I'm going to speak a little bit today about the role of the dietitians in clinic. I thought I'd share a couple of examples of what children are eating to show how difficult diet is in BBS. I want to show a few of our outcomes from our service, and I want to finish with some ideas that I've been having about how we can make the service better. And that's when I really appreciate feedback about what people think would work better. Thanks. So to start with, to set the scene a little bit, you know the clinic started back in 2010. So I've been working in the clinic since April 2010 at GOSH. And I thought it would be helpful to share some comments about the dietetic care that families have had that would be replicated in any of the centres around the country. So the comments about the dietitian from a satisfaction survey back in 2013 said the dietitian was very approachable and understanding to the needs of children with BBS. The dietitian was knowledgeable and non-judgmental. Dietitians outside of BBS do not have a full understanding of the impact food has on our children. Great to discuss with somebody who actually does. Able to brainstorm ideas with someone who actually fully understands the implications of BBS. So that's just a little bit to set the scene. So now to talk about how the dietitians work in the clinic. So there's a specialist BBS dietitian at each of the 4 centres, and they see everybody that attends their clinic appointments. The paediatric dietitians at Birmingham Children's Hospital and at Great Ormond Street also take part in the mini telemedicine clinics that happen between the big clinic appointments that happen now about every 2 years. And this allows us a quick check-in about diet-related concerns. So they might be growth, weight gain, diet, activity. And sometimes if there are concerns, we will do a separate telephone follow-up. Please remember that you can contact your dietitians between clinic appointments. And at GOSH, that would be by using the My GOSH app, telephone or email. And all of us will refer to local dietitians for ongoing input between the big clinic reviews, because now people aren't seen for a couple of years. I thought it might be helpful for a bit of understanding about how dietitians learn about BBS to see if anything has changed since I qualified. I'm one of the older members of our dietetic department, so I asked my colleagues to see if they'd learnt anything when they're at university. And it might not surprise you to hear that nobody had any training about dietary management of BBS at university. And only 6 people, which was about a third, had been taught about hyperphagia. And that was in the context of other conditions, things like Prader-Willi. Of my colleagues, most people hadn't had any experience of working with somebody with BBS before they started at GOSH. And that's quite shocking because a lot of my colleagues have worked in many other departments around the country. So I wanted to highlight how the specialist clinic dietitians learn about BBS. When I first took on the job, I met with Professor Biedl, and he asked me about my experience with BBS, and I talked to him, and then he shared so much information so that I was which I wish I'd known for the children I've worked with previously. From the beginning, I've had so much information from the BBS UK clinics team right at the back at the beginning. Every clinic, I was asking Julie and Tonya information, I was emailing them between, and that continues now. We've got a great working relationship. Angela's on my speed dial, and I learn all the time from them. But most importantly, we learn from the experience of working with our families or our adults. Every clinic, we will give advice, some ideas that people might like to try, and then they'll come back and say what's worked or how they've adapted some of that advice. And it's that information that we share with the other families. I've also learned loads from attending the conference over the years when adults and families have come up and chatted about things that have worked, things that haven't worked, what they wish that all dietitians knew. And that's so useful, and I'm so grateful for that. I've now thought it would be useful to reflect on what all dietitians need to know that are working with people with BBS. And these are the things I wish I'd known a little bit earlier in my career. So we know that adults and children with BBS have lower energy requirements, and this makes dietary management really challenging. We know that requirements are specific to an individual. I'm often asked, how can I calculate the requirements for an individual? And there isn't a simple calculation. Anyone that is going to see a dietitian outside of the clinic and in the clinic are really motivated, and we need to remember that. We need to think about hyperphagia and food-seeking behaviour. We need to remember that challenging behaviour can be a real concern for many of our families, and we need to make sure that any advice around activity needs to be accessible. We need to think about vision changes. If someone doesn't like loud noise, that any advice is suitable. Now, I thought it would be interesting to highlight to anybody that's listening that doesn't know how challenging diet in BBS is by sharing a couple of real examples. So the kids coming to clinic are asked to complete a food diary, giving 3 typical days of what they're eating, and then we analyse it and send a diet report afterwards. So this is an example of a 6-year-old boy that was attending our clinic. So for breakfast, he has 2 Scotch pancakes and skim milk. Mid-morning, a small banana. Lunch, a sandwich with reduced fat spread and a reduced fat cheese, with a decent portion of vegetables on the side, tomatoes, cucumber and olives. Pudding was a bowl of mixed berries and grapes and a small low-fat yogurt. And then mid-afternoon, a clementine. His evening meal was a homemade pasta bolognese, which contained at least 2 vegetable portions. The portion of pasta was controlled. It was a tablespoon, had a sprinkling of cheese over the top and a small slice of garlic bread. And then a low-fat yogurt. Bedtime, 100 mils of skim milk. All his other drinks are water. And I just want you to think about other 6-year-olds that you know and what they might be eating in an average day. So you can see from this example that the child's eating plenty of fruit and veg, definitely hitting their 5 a day. There's controlled portions at meal times. There's no sugary sweetened drinks there at all. There's lots of foods that other children might be eating, not on that diary. This intake averages at about 1,300 calories a day, and the average requirement for a 6-year-old boy would be about 1,600 calories a day. So despite that, this marked reduction in total energy intake, his weight was increasing rapidly. We did a few diet tweaks and talked about activity, and since then his weight is coming down beautifully. The second example is of a 12-year-old girl attending our clinic. So for breakfast, she has 2 shredded wheat skim milk, a pear, a slice of toast with peanut butter. Lunch is a bagel with jam and cheese. Again, a portion of vegetables on the side, carrot and pepper sticks. A small banana for pudding. Evening meal. I've mocked up a plate at the top right-hand corner of the screen to show you the sort of size portion this reflects as. So it's a small portion of cooked chicken, which covers about 1/4 of a plate, with 1/2 teaspoon of sweet chili sauce. 1/4 of a plate is covered with mixed grains, in this case, which is quinoa and a variety of different types of rice. And 1/2 her plate is covered in vegetables, which are peas and carrots. Her dessert for her evening meal was strawberries. You'll notice there's no snacks. In this example, she drinks water between her meals. And this is possibly very different to many 12-year-olds that are at high school, all sorts of access to food. Her average intake was about 1,200 calories a day. And with this reduced energy intake, she is able to maintain a healthy weight. Her BMI is in the healthy BMI range, which is incredible. It's a real achievement, but it can't be easy to do this. And she's eating a controlled diet, but she is also very active. Now moving on a little bit to some outcomes about weight. So we know from studies in the literature that about 72 to 86% of adults with BBS are living with obesity. Until this year, there was very limited data in the literature about patterns of weight gain in childhood, but there's an excellent paper by Dr. Jeremy Pomeroy that's published in Pediatric Obesity this year, which discusses weight changes in childhood. But we've also been collecting data since we started in the clinic at Great Ormond Street, and I wanted to share some of that data because I hope it gives a sense of hope about managing weight. So when we started our clinic, the first year, none of the children attending our clinic had a BMI in the healthy BMI range. But since then, we've published data on our outcomes page, which if you want to look at, you just Google GOSH clinical outcomes BBS and the page pops up. So we've published our results for the period between April 2017 and March 2020. And on average, 9% of our patients have been able to maintain a healthy BMI, which is incredible. But I'm also much more excited by the fact that about 60% of our patients have been able to reduce their BMI Z score between appointments. And it sort of challenges the idea that weight or BMI has to increase with age. It is hard work, definitely. It's not easy. Diets in BBS is very challenging, but it is possible to have some really good outcomes. I thought it was useful to share that those children that we've seen in that period that had a healthy BMI didn't just all appear in our service with a healthy BMI. There's only one of the 7 children that has had a healthy BMI all the way through the time that they've been seen in the service. But seeing that child in clinic, the diet control is really, really impressive, and it's not been easy. But I thought it would be possibly useful to share that over half of those 7 children, so 4, achieved their healthy BMI on their 4th or 5th visit. And if our clinic appointments are about 2 years apart, that could be sort of over 8-10 years. But I hope it shows the benefit of attending the clinic. And just to finish, we need to always think about what we're doing in clinic and think about how we can make some improvements. These are my ideas, but I really welcome your ideas. So my first is really around dietetic referrals. I've mentioned already that there isn't much information for dietitians about diet in BBS out there. We're not taught about it at university. It's not in our standard textbooks. There aren't many papers in the literature that focus on diet. So can we improve the process of the referral to a local dietitian by actually phoning and speaking to that dietitian that you're going to see? It would allow us to check the local care pathway, make sure that you're not just being offered a one-off appointment and then being discharged, but it would also allow us to discuss diet in BBS. Trying to think around the logistics of how we could do this, because currently if we make a referral, it's in the MDT report coming out of the clinic, and then it's another person that refers to the dietitian. So maybe it would be a case of someone contacting their dietitian to say, I've now got an appointment with whoever, wherever, could you phone them and have a chat? We also need to think, is there someone better placed to provide support with weight management between appointments? One of our families had the most amazing nurse specialist involved that went in to visit them at home regularly, and we liaised and then altered diet that way, and the child has done amazingly. And if we could replicate around the country, that would be amazing. As paediatric dietitians, I think we need to involve the school team more. There's been a couple of our families where we've had regular contact with school staff, and it's had really positive outcomes in terms of diet, expanding the range, getting fruit and veg eaten, and in terms of weight change with weight reductions and increased activity. We need to educate others within the wider team in the hospitals that we work and within the networks that we work in, because they may have contacts with our families, with adults, For example, there's a therapist that has been working with one of the children in our clinic for a number of years, and we saw them together, and that was the first time that she had realized that children with BBS have lower energy requirements and this desire to eat, which is why weight management is so challenging. And then she's been able to see the child more often and provide ongoing support. I think more frequent monitoring would really help. Big life events occur between our clinic appointments. In children, that might be starting school, changing school, learning to walk. But this last year has just shown how difficult life can be at different stages. And if we can have additional weights and heights between appointments, that would help. I do offer for families to send in data to me between the appointments, but tomorrow you'll hear about the home monitoring equipment piece of work that's going to be started on our service, because we've been lucky enough to get the funding. And I would encourage everybody to send in their weight and height data, etc., when they're told to do it, because it can really help. It gives us extra information, so we might be able to identify difficult times in life and see if we can make things different. But it also gives the opportunity for you to contact a dietitian and ask them for advice if you're struggling. And the final thing I think that could help is really some sort of accessible dietary information for our families, but also for other professionals. So we've been working on 4 diet sheets that we commonly use that I hope that will be up on the Trust website soon, so families can download them between their appointments. And that would be around portion control, increasing fruit and veg, snacks, and information for schools. And thank you very much to the families that have helped review that information, and we'll let you know when they're live on the website so that you can download them. I hope that also means that local dietitians will be able to download that information. And perhaps the final thing we can do as dietitians is write something about diet and BBS that can go into Dietetics Today, which is the publication that goes out to all dietitians in the UK, or publish something in the Journal of Human Nutrition and Dietetics to just raise awareness. So that's it from me, but I would welcome any feedback. Thank you.